every one of you for this nice opportunity. Thank you.
Dr. Richie Solomon, please.
Good evening, everybody. I would like to thank everyone for giving me this opportunity to moderate this session. I think it will be a good learning for all the postgraduates. I think we'll start with the session.
Yeah, thank you. Now, Dr. Rekha, you can start. Yeah.
A very good evening to all my respected professors and attendees present here. I am Dr. Rekha, Junior Resident from Tirunelveli Medical College. I would like to thank IAP TNSC panelists for providing me with such wonderful opportunity to participate in this PG teaching program. I am here to present a case of critical cyanotic congenital heart disease. Okay, Kamalesh, 1.5-year-old male child, resident of Surandai, first born out of third-degree consanguineous marriage, a known case of congenital heart disease, operated on regular follow-up at Tirunelveli Medical College, who has attained age-appropriate milestones, was brought by his grandmother, whose reliability is good, has now come to Tirunelveli Medical College with complaints of bluish discoloration of lips and fingers noted for the past 5 days. Episodic increase in bluishness with breathlessness noted during crying. As problem started in neonatal period, I would like to start from antenatal history.
Now, may I make a request to the presenter? Could you please go a little slow? Could you move on to the first slide? You're too fast for me to follow.
Okay, sorry.
Yeah, go ahead.
Yes, Kamalesh, 1.5 years old, male child, resident of Surandai, first born out of third-degree consanguineous marriage, a known case of congenital heart disease, operated on regular follow-up at Tirunelveli Medical College, who has attained age-appropriate milestones, was brought by his grandmother, whose reliability is good, has now come to Tirunelveli Medical College with complaints of bluish discoloration of lips and fingers, noted for the past 5 days. Episodic increase in bluishness with breathlessness noted during cry.
Thank you very much. Go ahead. Yeah.
As problem started in neonatal period, I would like to start from antenatal history. Antenatal history. Mother married at 21 years to her first cousin, who was 24 years old. Third-degree consanguineous marriage. Had regular 28 days menstrual cycle. Conceived after 3 months of marriage. Confirmed pregnancy by urine pregnancy test at 45 days of amenorrhea at Surandai PHC, where she was registered. Regular antenatal visits at the same hospital. No history of periconceptional folic acid intake. Not a known case of diabetes mellitus, hypertension, hypothyroid, asthma, seizures, connective tissue disorders. No history of excessive vomiting. No history of fever, rash, painful swelling behind ears. No history of drug intake, alcohol, smoking, irradiation, trauma. Dating scan done at 3 months was said to be normal.
Now, doctor, I'd like to ask you, you have said so many no's. What would be the relevance of all those no's to the problem at hand? Now, you are dealing with a baby cyanotic heart disease who has been operated upon, who is now presented to you with increasing bluishness, intermittent bluishness. Now, very nicely you have given this, the family background, the marriage, and the pregnancy, etc. But you have mentioned so many no's. Can you put some relevance to those no's?
History of periconceptional folic acid intake. No history of periconceptional folic acid intake is my first no. This periconceptional folic acid intake should be given to all the mothers. It should be taken at before 3 months of conception to prevent any neural tube defects, and that could be associated with the cardiac diseases also.
Wonderful, wonderful.
Yes, sir. And the second no is she's not a known case of diabetes mellitus, hypertension, and hypothyroid, asthma, seizures, connective tissue disorders. So each of these diseases are connected to some of the congenital heart disease and associated anomalies that may present in the child as newborn.
Very good.
Yes, sir. And no history of excessive. Yes, sir.
You mentioned about fever, rash, etc. Can you have some relevance on that?
Fever, rash, and painful swelling behind ears for the mother. It may be due to some congenital, it is due to the infections such as rubella. This congenital rubella syndrome in a child may cause congenital heart disease.
Wonderful, wonderful. Very good. Please go ahead.
Second trimester, quickening was felt at 5th month of gestation. Anomaly scan at 20 weeks of gestation said to be normal. Took iron and folic acid tablets regularly. DT, 2 doses were given at 4th and 5th month of gestation. No history of pregnancy-induced hypertension, gestational diabetes mellitus, seizures. Third trimester, perceiving fetal movements well. No history of bleeding, draining per vaginum. No history suggestive of COVID-19 infection, urinary tract infection, and other infections. Growth scan done at 7th and 9th month said to be normal. Growth and vigor is adequate. Had a weight gain of 11 kgs throughout the pregnancy. Total EMSH is 6. Birth and neonatal history. Mother developed labor pain at 1 week before EDD at 6 p.m. at her residence, and she was taken to the hospital at around 8:30 p.m. She was taken to private nursing hospital where she delivered a normal term boy baby of birth weight 2.8 kg, cried soon after birth, but has respiratory distress and bluish discoloration immediately after birth. Baby was admitted, oxygen therapy was initiated, and IV line secured and transferred by neonatal ambulance to Tirunelveli Medical College at 6 hours of life for further management, where the child was admitted for respiratory distress and cyanosis and evaluated in Tirunelveli Medical College. Said to have cyanotic congenital heart disease, managed in NICU, level 3 care with oxygen therapy, IV fluids, IV medication, and supportive care.
Doctor, I would like to interrupt you at this point if you don't mind. Now, were you surprised to have see this newborn with such a severe congenital heart disease, yet the prenatal, the ultrasound prenatal growth, they were all normal? So were you surprised? Was it, how come there was no clue whatsoever as to the presence of a structural heart disease in the unborn baby? People come to know about this only after the baby was born. How do you explain this?
Sir, because of the fetal circulation, which is solely not involving the lungs, the main blood flow is through blood circulation is due to placenta and the uterine arteries, and the baby has not developed sinuses further in the newborn.
Okay, wonderful.
Yes,
yeah. Now, 2 other moderators, would you like to ask her any question at this point? This baby was born term and had a very serious congenital cyanotic heart disease, yet, prenatally, nothing was really noted, and she explained that. And they could have a lethal heart disease, yet in utero, they could remain relatively well. Right.
Yeah,
now, I'd like to ask you, please go ahead.
I would like to ask the presenter whether she could gather any details about the anomaly scan. Where was it done?
It was done at PHC.
Okay. You want to give any importance to that?
Usually the anomaly scan should be done by an expert radiologist.
Okay. So what is the normal difference between an anomaly scan and routine ultrasonogram done in PHCs?
Usually the routine PHCs physicians might have done the anomaly scan.
Not with regard to the person who's doing it, but what all do they look at?
They look for the major congenital anomalies that are not missed during this. And
okay, so during routine scans, basically they look into the fetal heart rate, they look into the ventricular function, and any fluid collection around the heart. And most of the persons who do that ultrasonogram at PHC level, they would be able to pick up major heart defects which involve the septum. Okay, so anomaly scans. In anomaly scan, they have a specific protocol where they look at the 4-chamber view, then the 5-chamber view, and they try to look into the outflow tracts also. And associated with that, they also try to pick up abnormalities in the pulmonary venous drainage. Probably a good anomaly scan, they would be able to pick up most of the congenital heart defects, but there is a chance you might be able to miss some obstructive lesions like coarctation of aorta and sometimes pulmonary venous abnormal pulmonary venous drainage, which is quite difficult to pick up. So when an anomaly scan is done in a tertiary care center by a trained person, usually they would be able to pick up outflow tract anomalies and the major critical congenital heart disease. So there is a possibility sometimes they might be missing some major congenital heart anomalies by doing anomaly scan at the PHC level.
Okay.
Shall I continue?
Doctor, I'd like to ask you, suppose you were the initial responder to this baby. You were the first pediatrician to have received the baby soon after birth. Or they say you were in the labor room. The baby had cried immediately, but subsequently found to be bluish, but was also in respiratory distress. What would you do? You or the medical officer in the labor room, or the baby is given to you? What would you do? You find a newborn who is bluish, but who is also in respiratory distress.
Yes, Rini, you can answer.
Huh?
Rini,
Beg
you
your
can
pardon?
answer. Rini and Nikhil.
No, would you straight away think of cyanotic heart disease and simply call the cardiologist, or as an initial responder, what would you do, or what would you think?
I'll manage with O2.
How about your other colleagues? They can also participate in answering this. You see, I am a general pediatrician. I am not a
Target
cardiologist.
saturation should be noted.
Beg your pardon?
After initial stabilization of the baby. After initial stabilization
No,
of the baby.
my question, no, one moment.
My
My question to all of you is this. You are in the labor room, the baby had cried and has become blue, it's persistently blue. So what would you do? And is in distress.
What are the other responsibilities for cyanotic baby, no? At birth. What are the other causes for no?
There will be cardiac causes and non-cardiac causes. So
So how will you
No.
manage?
Now, let me tell you, doctor, I had faced this situation years ago in the labor room. You should think of all respiratory causes of cyanosis, which are remediable, far more frequent. See, it could be a small chin. It could be a large tongue. It could be a goiter. It could be, a pneumothorax. It could be a diaphragmatic hernia. So your effort, if the baby, especially in distress, you should think of, pulmonary cost, treatable causes in the respiratory tract. Simultaneously, you must think of them. Besides considering, cardiac cause. Suppose you consider, let us say, a diaphragmatic hernia. Baby is in distress, is blue. What would you do?
immediate intubation, sir, because
What would you do?
Decompress the stomach. And start with the
decompress the stomach with NG tube and then intubate.
Absolutely. You decompress. And then what is that you won't do? What is that you won't do?
Child on hospital for ventilation or intubation, sir.
wait for
What is that you
24
would
hours
not
and
do?
wait for the pulmonary.
we will not give bag and
We will not give the bag mask ventilation.
Okay, very good. You will not do bag and mask. You will, okay, wonderful. Please go ahead. Now, the point that I am making to all of you is this. A bluish neonate in the labor room or the first few hours, cyanotic is not the only condition. You should consider more frequent, pulmonary airway causes, because they are all amenable to interventions. Oftentimes they are in distress. That's what I'm mentioning. Okay, that's the point. I hope my moderator also would agree with this concept.
Can one of the PGs list the respiratory causes of cyanosis in newborn?
Okay, go ahead.
coronal atresia, starting from the middle, coronal atresia, bilateral coronal atresia, laryngomalacia, severe,
No more
A large tongue.
serious.
So you have listed the airway anomalies. Okay, coronal atresia, laryngomalacia,
Airway anomalies.
micrognathia. What are the other causes, other lung causes, lung parenchymal causes?
persistent pulmonary hypertension,
No.
congenital pneumonia.
No, okay. I'm going to ask all three of you. How would you examine this baby? What would you how would you examine the baby? What would you look for? You are in the labor room. Okay, you're put in nasogas tube. You're not going to, ambu bag. You're going to get your intubation set, etc. But how would you examine this baby? What would you look for?
Anomalies. We look for all anomalies and external.
One at a time, please.
Anomalies and external congenital. We look for external.
No,
We look
please,
for external anomalies, sir.
No, be specific, please. I don't want the non-specific answer. Be specific. You are there in the labor room. You are the person, you're going to examine this baby, let us say on a warmer. So how would you examine? What would you look for?
By inserting an incision, we'll try to find if there is any final attrition or attrition.
How would you look for
And
bone
then,
attrition?
we look for a spot.
Okay, anyhow, in order to save time, let me tell you what I would do. That would be much easier. Now, what I would do, the baby is on a warmer, it's blue. Of course, you will administer oxygen. And then I would put the stethoscope over the nostrils, looking for egress of the air. Okay, egress of the air tells me likely, unlikely to be called atresia. Then I would look at the apical impulse to make sure it's on the left side. Now, if it is on the right side, I would worry about diaphragmatic hernia. Look for salivation. Excess salivation tells you there is esophageal atresia. Put your stethoscope in the infraclavicular area, look for air entry equally. Symmetrical air entry is against pneumothorax or obstructive emphysema. Okay, you palpate the chest. So these are the immediate things you should do besides looking at the peripheral pulses, besides doing pulse oximetry. Nowadays, pulse oximetry. So the point that I'm driving to all three of you is this. A cyanotic newborn in the labor room on the first few hours, first few days, not only congenital heart is cyanotic, but you should think of all these respiratory causes, which you can pick up by simple physical examination. And then what investigation would you do? Let us say you're in the periphery, cardiologists are not available, ECG is not available. You are in a primary center. What single investigation would you do? Absolutely. A chest X-ray is a must. That gives you an awful lot of. Please proceed. I don't want to take more of your time. Go ahead.
Baby has said to have a cyanotic congenital heart disease managed in NICU level 3 care. Hello, sir. Am I audible?
Yes, you are audible. Proceed.
Okay. Now, again, with the my moderators must I need their permission to talk to them further. Doctor, you have done this examination. Let us say the baby is intensely blue. There is no pulmonary cause. Let us say there is no neurological or hematological cause. We think only in terms of a cyanotic and heart disease as the cause for blueness. What other immediate measure would you do, even before calling the cardiologist? Because you are going to get a pediatric cardiologist. What other immediate measure would you do? Of course, you have the pulse oximeter, you see the pulse. Yes.
Duct dependent patients.
Absolutely. So what would you have at bedside? And after speaking to the cardiologist, you should also use it. What should you have?
So what's the bedside thing you would do to pick up a critical congenital heart disease?
Pulse oximetry.
No, pulse oximetry supports your diagnosis of heart disease. There is a difference in the pulse oximetry. Right, hand and right foot or left foot. It is, let's say, more than 5% or even start with less than 90%. And with oxygen, it doesn't improve. So clearly tells me it's a cyanotic heart disease. See, late Dr. Alexander Navdas used to say, it's of course an oversimplification. When the babies become less blue with the crying, is most likely pulmonary. If it gets worse with crying, it's most likely cardiac. But that's a very oversimplification. But nowadays, your pulse oximetry to tell you that. So what is that you should have at bedside? With the knowledge, let's say permission of the cardiologist, you can use it. You can use it to gain some time. What is that? What is that I'm thinking about? Huh?
Medication.
Absolutely, to keep the ductus open. That's another, see, at the primary care level, even though you're not a cardiologist, as a general pediatrician, you will be called to be in the labor room. You will receive these babies, and then you should know, how to proceed further, what to look for, and think of these causes, and then also immediate measure. Okay, go ahead.
Cyanotic congenital heart disease managed in NICU level 3 care with oxygen therapy, IV fluids, IV medications, and supportive care. Passed urine and meconium. Referred to higher center for early cardiac intervention at day 12 of life as per cardiologist opinion at Sri Chitra International Medical Hospital, Trivandrum, where the child was admitted and treated surgically at day 14 of life. Post-operatively, baby was maintained.
Rega, I think you are using a double device. I think
Echoing, yeah.
one thing you mute, please. Echoing.
Post-operatively, baby was maintained on ventilator support. Other drugs were given. Oxygen support and weaned from oxygen support on post-operative day 7. Feeds initiated, and after uneventful course, discharged at 40 days of life. Child was advised to continue 2 types of tablets daily. Danger signs explained to the parents and were advised for follow-up periodically. Parents were briefed about the need of corrective surgery later. The child was on regular follow-up at Tirunelveli Medical College at 6 months and 1 year of life, during which the weight gain and development was normal. Mother didn't notice any feeding difficulty, poor weight gain, decreased activity, respiratory distress, or worsening cyanosis.
At what day of life the surgery was done?
At day 14, sir. Surgically treated at day 14.
Day 14. And bluish discoloration was noticed immediately after birth.
Immediately after birth.
So, what do you think would be the differential diagnosis if you have to think about the cardiac causes for cyanosis in a newborn?
So at birth, there may be tricuspid atresia with pulmonary stenosis. Then the TGA with the pulmonary
Reka,
stenosis.
tell the common causes first. Knowing
TGA
about
with
the
the
case. Yeah.
No,
TGA
doctor,
with the
to answer the moderator's question, could you please categorize this function? Instead of
Always better to group it up.
mentioning individually, can you make a functional classification as a pediatrician?
Yes, sir.
Because
So
he
cyanosis-
asked you, make a
Cyanosis
functional
can-
classification. Could you please tell him that?
Cyanosis may be due to increased pulmonary blood flow to the lungs or due to decreased pulmonary blood flow to the lungs.
Okay.
So, for the case of decreased pulmonary blood flow to the lungs, there will be severe cyanosis that may present at birth, noticed by the mother itself even. So, the causes are TGA with pulmonary stenosis, tricuspid atresia with pulmonary stenosis.
Tricuspid atresia will produce increased blood flow?
Decreased blood flow. Yes, sir. With the pulmonary stenosis will produce decreased blood flow.
I don't know. It's up to the moderator to say that. Okay, fine, go ahead.
Presence of tricuspid atresia with pulmonary stenosis, there will be decreased pulmonary blood flow. Tricuspid atresia can happen with either pulmonary stenosis or without pulmonary stenosis. So with pulmonary stenosis, there will be decreased pulmonary blood flow.
So again, doctor, all three of you are in general pediatrics. Now you're going to interact with pediatric cardiologists. When you interact with the pediatric cardiologists, we have to be knowledgeable so that they also learn to respect us. So to answer his question, right ventricular outflow obstruction and left ventricular outflow obstruction. You have to think that way. So right ventricular obstruction, there are a number of lesions. They all give rise to decreased pulmonary blood flow. And then there are left ventricular outflow obstructions, which could give rise to congestion. So you have to think that way. So then there are some overlapping. Okay. All right. Go ahead.
What are the lesions you'll think under increased pulmonary blood flow?
Increased pulmonary blood flow, with TGA without the pulmonary stenosis, truncus arteriosus, hypoplastic left heart syndrome.
Okay.
Truncus arteriosus, TAPVC,
TAPVC.
and all single ventricular physiologies. It could be
Yeah,
complex
okay.
DVRDs, common AV canal defect, which is unbalanced. Without pulmonary stenosis, they also come under the hemodynamic classification of cyanotic heart disease with increased pulmonary blood flow.
Okay. I'm going to ask all three of you, again, with permission of the moderators. You see, this is a baby that presented with intercyanosis, you said respiratory distress. Now, the congenital heart disease, what are the other two presentations that have some relevance? In the newborn period, there are two other presentations you should know. They also may be little bit cyanotic or dusky.
Other diseases, sir?
No, I am not. See, I am not a cardiologist. I am not worried about individual disease at all. That is, I'm going to leave it to them. They are going to manage. But as a general pediatrician, what I am interested is to arrive at a physiological and functional classification so that I can proceed further. Now, this is a baby that's intensely cyanotic, so obviously hypoxemic. There's a severe degree of hypoxemia. But what are the other two presentations? in the newborn period, you may be called to see, they may be sometimes dusky, not exactly that intensely cyanosed. It has some relevance to the, just, you know, Dr. Solomon just mentioned. You also mentioned. Have you heard of babies coming to you on the 5th or 6th day with a shock-like picture? They may also be dusky. Huh?
Quiet place na quiet.
Beg your pardon?
Duct dependent lesions. Which closes after 7 days.
So hypoplastic left heart. Okay, left ventricular outflow obstruction. See, what I like, you know, as a general pediatrician, all I would like you to do, don't get lost all this in byways and side lanes and all that. It will not help you because the pediatric cardiologist is far more knowledgeable, a lot of expertise, they will take care of it. But as a general pediatricians, you have to make a diagnosis of left ventricular outflow obstruction with shock-like picture, which means either a aortic arch, which is completely interrupted, or aortic atresia, or bipolar left ventricle. That calls for a different approach. Now, right ventricular obstruction, that calls for a different approach. And there is one more presentation, which may not be relevant to the baby that you're going to discuss, but nevertheless, you need to know that at 15 days or 21 days, they come to you with another picture. What is that?
Persistent pulmonary hypertension.
No, the pulmonary hypertension, you know, it's a cyanotic baby. It's very difficult to find. We'll come to that. And more common ones. You know, babies can come to you. She said distress. She said tachypnea, tachycardia, and let's say the pulse is a little bit bounding. The baby is in heart failure. So what do you call that? What do you call that syndrome? Pulmonary overcirculation syndrome. So in other words, what I'm trying to get across to you as a senior pediatrician is this. If you have a newborn at the first few days of life, is intensely cyanotic, think of non-cardiac, especially respiratory causes, airway, lung, etc. And then think of cyanotic right ventricular obstruction as well as left ventricular obstruction. Now, in case of left ventricular, you will have shock-like picture. That won't be the right ventricular obstruction. You have failure-like picture, that is pulmonary overcirculation. So you have to think all these three. If the baby that's brought to me critically sick, is cyanosed, mild, moderate, or intense. Is it a shock-like picture, which means I worry about left ventricular obstruction? Is it a pulmonary overcirculation? I worry about left-right stents, pulmonary congestion. And then it is intense cyanosis, right ventricular obstruction. This is the functional diagnosis you should make. The rest of the cardiologist is going to deal with it. We are not going to deal with it. So make a functional diagnosis. So in this child, I would have diagnosed a functional diagnosis of a right ventricular outflow obstruction with intense cyanosis. Now, having said that, I'm going to ask you one more. You said I would take at the periphery an immediate chest X-ray. Of course, I would do pulse oximetry. I would give oxygen. I would have vascular access. I would have prostaglandin, everything get ready. But then you are given a chest film. The chest film looks like a RDS, hyaline membrane disease. What cyanotic heart disease you are worried? That's the only, if you have a chest X-ray of a cyanotic newborn, it looks like an RDS, but the baby is not a premature.
Total anomalous pulmonary.
Absolutely. You are absolutely right. You are absolutely right. You are right. You are right. So this is how you, as a general pediatrician, approach a cyanotic heart disease. Okay. Now, of course, you have to interpret. Please go ahead. I leave it to the moderators now. Okay.
It's a TAPVC, right? When it presents with X-ray picture suggestive of HMD, what type of TAPVC would you think of?
Yeah, correct. That's a very relevant question.
Obstructive
So does it give you a clue about the morphology of the TAPVC? Where is it draining?
Usually it drains into
In other
the
words,
right
which type of
atrium.
TAPVC has the highest association with obstruction?
Infracardiac.
Infracardiac.
Nearly 100% obstructed. Very rarely you can have a supracardiac TAPVC where the vertical vein is compressed between the left bronchus and left pulmonary artery, which could be obstructed. But generally, when you face a newborn with obstructed TAPVC, it is mostly infracardiac TAPVC, and it is probably the only surgical emergency for the cardiothoracic department. Okay.
Now, doctors, again, I'm going to ask you the chest X-ray. Again, see the tool that's available to me, chest X-ray. How about the comment about the heart size? And tell me normal heart size, cyanotic with the big heart size. See, one is looking at the lung fields, oligemic or hyper. In most instances, the heart size is normal in cyanotic, but in a few instances, the heart size is enlarged. Can you make an educated guess what that could be? Beg your pardon? Yes, you are right. Yes.
and PJ.
Yes, total anomaly without obstruction. Yes, right. And truncus arteriosus. Okay, good. So in other words, you normally there's oligemic. Normally heart size is normal or small, but occasionally it could be enlarged. There could be congestion in the lungs. I'm going to ask you one more. You said this is a baby with breathlessness. Now, most cyanotic babies, they are usually quiet. They are not that breathless because there is not much of a flow, blood flow into the lung. So when you have a breathlessness, watch out. It may not be it could be a more complex problem, or it could be, as I have been repeatedly telling you, it could be a pulmonary or non-cardiac. Okay. Suppose, doctor, you have a cyanotic newborn. Let us say you take the blood for CBC and the blood is chocolate brown. Huh? Okay. How do you? Okay, fine. Okay, that's important. Okay, good. Right, go ahead further.
There is one question from Dr. Piazzi, sir. What would be the characteristic of cyanosis in bilateral choanal atresia? Would you like to answer it?
Dynamic cyanosis, sir. It will be during the crying, there will be no cyanosis, and when the child is quiet, the child will go in for cyanosis.
They basically call it a cyclical cyanosis. Okay.
Correct.
How do you get intermittent cyanosis? Structural cardiac defect.
Stuttering.
Okay.
Neonatal Epstein's. Okay. Sometimes in neonatal Epstein's, because of the high pulmonary artery resistance initially, there will not be any pulmonary artery blood flow because of the high PVR. So for a few days, the baby might be cyanotic, but there is no functional pulmonary valve obstruction. There is no anatomical pulmonary valve obstruction. So as the PVR falls, the forward flow across the pulmonary artery increases. So after some time, the cyanosis disappears.
Okay. Now, let me tell all three of you, the learners, the cyanotic heart disease, it is a life-threatening emergency. You and I will not be able to handle it without the help of a pediatric cardiologist. It is in their domain. Please remember, the pediatric cardiologist is the person who has expertise knowledge to handle these babies. We are there to make an intelligent judgment, to stabilize the baby, and then get in touch with the pediatric cardiologist. Nowadays, using digital phones, digital media, and stabilize the child, and then immediately make arrangements for a transport. So this is all very much in the domain of pediatric. I'm going to ask you one more question for benefit of the learners. Now, let us say I listen to the heart sounds of this baby. Normally, heart sounds, with the breathing and movement, the variation is there. But it so happens, I was, about 24 hours of age, I happen to see a newborn, absolutely quiet, tachypneic, dusky over the peripheries, and our tongue is not really that dusky. I put my stethoscope, I get a heart rate, which I'm unable to count. What do you think? What do you think is happening? I listen to the precordium. Yes?
Pneumothorax.
No. See, I'm giving you a picture where I put my stethoscope. I get a feeling the heart rate is too fast, which I'm unable to count.
Arrhythmias.
What arrhythmia? Absolutely. This is something you should know. Supraventricular tachycardia, it's a fixed rhythm. Indeed, Dr. Alexander Nadas, if you take the old monographs and read, you put a timepiece under the pillow and you put your head, you will have a tick, 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 no fluctuation. That's immediately should alert you, you're dealing with a supraventricular tachycardia. Now, in advanced stages, they could be cyanotic, peripheral cyanosis. Okay, now, yeah, unfortunately, see, this is a child that was diagnosed, operated upon. So many aspects of learning, unfortunately, we cannot pass it on to you because already diagnosis is made. So, but on the other hand, the newborn baby, you look at the blueness, I said it's an emergency, but then I look at the tongue, which is pink. What's happening? The soles are blue, but tongue is pink. Yes, what do you call that? Yeah, this is the commonest cause of cyanosis. Acrocyanosis, the commonest cause of a very benign, harmless cyanosis. Okay, now what this is a type of peripheral cyanosis. But then there are other situations in practice, you will see the peripheries are cold and dusky. Perioral areas are also dusky, bluish, and they are not warm but cold. So, you know, I used to do, I must tell you, in the newborn, neonatal wards, whenever soles were actually found to be dusky, I would rub the soles. You rub the soles for a minute or two, look at the rubbed area. What would you find the rubbed area? I have rubbed the area, which means I have improved the circulation, I made the area warm. So the rubbed area becomes pink. The rubbed area becomes pink. The surrounding area is blue. So that is a hallmark of acrocyanosis. Now I'm going to ask you, what is cyanosis due to?
Vasoconstriction.
Huh? No, what is cyanosis due to? Bluish discoloration, what is it due to?
Deoxygenated hemoglobin.
One at a time, please. You know, when you have a pallor, you know, the hemoglobin is low. When you have a jaundice, bilirubin is high. When the baby is blue, what is it due to? What is the hemoglobin that imparts bluish color? Reduced or deoxygenated hemoglobin. What should be the level? What is the level? What should be the level per grams percent? No. Now you be clear. Speak clearly and slowly.
Yes. Decrease of more than 3 grams per deciliter.
You are right. So the reduced hemoglobin has to be more than 3 grams. Now, what is the average hemoglobin of a newborn, healthy newborn?
16 to 18.
16 to 18. So they have a very high hemoglobin. So you know, it's relatively easy, you know, for the cyanosis to appear. So okay, you're right, more than 3 grams of hemoglobin. Now again, I don't want to go into all this, you know, all this congenital heart disease discussion. I'm going to ask you in terms of physiology, you know, what are the physiological, you know, explanations for this reduced hemoglobin? Give me physiological explanations for the reduced hemoglobin. Hypoventilation, could it increase? If there is a barrier to the diffusion of oxygen in the capillary, pulmonary capillary, could it increase? Could there be a shunt in the lung where the blood flows but no oxygenation? Could it give rise to? And of course, deoxygenated blood passing through the heart could give rise to. Right? And how about this, you know, hypoglycemia? How about sepsis? How about shock? How do you get cyanosis there?
Reduce circulation.
Oh, yes, you're right. Go ahead.
Peripheral vasodilatation.
No, make it clear.
Circulation failure, sir.
Being circulation? No,
Peripheral
Increased capillary permeability and assurance.
No. Okay, in all these, you know,
Capillary.
hypovolemic states, shock states, you know, there is a sluggish capillary blood flow. And there is more time for oxygen to be extracted. and you have increased reduced hemoglobin, increase. So you have a cyanosis. In other words, even though the discussion is on bluish neonatal respiratory distress, which is very much in the domain of a pediatric cardio. If you ask me, it is the pediatric cardiologist who is going to handle it. You and I have only auxiliary role to play. But far more important for us to, whenever we have a bluish neonate or a bluish, infant, we have to think in terms of all these situations, which are more useful. Okay. Yeah, please go ahead. Please go ahead. I leave it to the moderators now. I think I have exhausted my way of looking at it. Okay.
So how do you specifically look for central cyanosis? Where do you look for central cyanosis?
Yes, very simple question. Yeah.
Rekha, you unmute your mic. Rekha, you are on mute. Your mic is muted. Yeah, yes. Now answer.
Around in the lips and the mucous membrane.
No. He specifically asked you,
look-
doctor, where do you look for central cyanosis? Very simple.
Around the lips and mucous membrane.
Why do we look in those areas specifically?
It's highly perfused area.
Is highly vascular areas.
Dense amount of capillary plexus is there.
Capillary
Then any other reason?
Easily accessible areas.
Easily accessible and visible.
Anything else? The epidermis is thin. Okay, in those areas, epidermis is thin, so it is more easily visible for us. Okay.
Visible.
All right. So please go ahead, doctor, with the presentation. I have given you all the basics and the differential approach. Now I leave it to the pediatric cardiologist to proceed further. Please go ahead, sir. Solomon, Dr. Anandi. Yeah.
The parents are re-submitted the corrective surgery later. The child was at regular follow-up and TVMCH.
Yes, other pages, please mute your mic. Yes. Rekha, proceed. Rekha, go fast. Yes.
The mother did not notice any feeding difficulties, poor weight gain, decreased activity, respiratory distress, or worsening cyanosis. As the mother was admitted for her second childbirth, the child was under the care of his grandmother. History of discontinuation of his regular medications. After 5th day of discontinuation of medication, the grandmother noticed bluish discoloration of fingers, toes, and lips with episodic increase in bluish discoloration, 1 to 2 episodes per day, suggestive of hypoxic spell. She noticed more when the child cries during hunger, while being bathed, straining during defecation, awakening from sleep. These complaints were associated with fast breathing during episodes. The discoloration got reduced on calming the child when the child is carried over shoulders or placing him in the hip.
No,
So what is that mother telling you, doctor? Very beautifully you have given the history. What is that mother telling you? What kind of situation is this?
Yes, sir. The child is getting cyanotic, she's getting cyanotic spells, and the grandmother is usually while pacifying the child, she is controlling the spell. It is a squatting equivalent.
So when did she discontinue the medication? How many
5
days after surgery?
after 1 year, sir. This is for the last 5 days she discontinued the child.
After 1 year. Okay.
Yes, sir.
So till 1 year, there was no history of any cyanotic spell.
Yes, sir.
But she noticed bluish discoloration.
After this 5 days of discontinuation.
Before that, she didn't notice any
Before that, she didn't
bluish
notice any
discoloration.
cyanosis, sir. No, sir.
So after surgery, mother did not notice any cyanosis.
No, sir.
Loka, all three of you, let me give you another practical tip. See, we are dark-skinned people. We are not Caucasians. We are not Chinese people. Our skin is not all that light. So, in the dark-skinned people, it's not that difficult to miss mild degrees of cyanosis. Very important to keep this point in mind. You have to examine them in good sunlight, never an artificial sunlight. That is very important, okay? And then if the babies are quiet with cyanosis, almost always central cyanosis is cardiac. And you beautifully mentioned the observation by the parents with excessive crying, it was actually getting worse. Okay, leaving this aside, doctor, not exactly in relation to this, but let us say there's a mother who brings the child to you. Doctor, my child becomes blue and he becomes unconscious. He jerks. What question would you ask her? So 6-month-old.
Is it because of any
What relevant question would you ask her when I give you this age? Yes.
Is he holding this breath while
Absolutely. That's what. Whether this child had cried vigorously prior to this episode, then they call breath hold. This is something you commonly see in your practice. Okay, go ahead. Go ahead, doctor. Go ahead.
Spells occurred frequently for prolonged duration associated with breathlessness, and the child has been admitted in TVMCH. These episodes were not associated with abnormal limb movements, cessation of breathing, or unconsciousness. No history of swelling of legs, abdominal distension, facial puffiness, decreased urine output, increased precordial activity. No history of vomiting, loose stools, fever, constipation. No history of skin rash or bleeding manifestations. History of adequate weight gain plus. No history of feeding difficulties. No history of recurrent respiratory tract infections or previous hospitalization. No history of previous similar episodes before the 5 days.
Doctor, whenever I listen to this retinue, so many no's, usually I begin to dose. You have so many no's, and then you have to think in terms of correlating these no's to the problem at hand. And of course, you can always find, for instance, you had asked for constipation and, of course, bleeding, polycythemia. Now, let me ask you, this particular baby, if you were to do, I already mentioned the examination findings, I won't repeat that. If you were to do a hemoglobin, a hematocrit, what would you expect?
Polycythemia.
You would expect?
Polycythemia.
Okay. If you were to do an RBC indices, what would you expect? When I say RBC indices, I'm talking about hemoglobin hematocrit ratio plus the MCV.
Hematocrit will be raised.
What is the importance of doing RBC indices in presence of polycythemia in a cyanotic child?
Correct, absolutely. So Dr. Solomon is asking you very good.
So what are the RBC indices you would like to know?
Role of iron deficiency anemias.
Yeah, so there is a high association with iron deficiency anemia with polycythemia.
Absolutely. Yes, Dr. Solomon has hit the head, nail on the head. Yes.
So what are the parameters you would like to look into? What are the RBC indices?
Like to look into the mean corpuscular volume, mean corpuscular hemoglobin, and mean
Anything else?
corpuscular hemoglobin concentration. Serum ferritin and transparent.
No. Only with RBC indices. Only with RBC indices, how will you diagnose iron deficiency anemia?
MCV and RBC. MCV and RBC.
Anything else?
Your basic hematology.
What is RDW?
Red blood cell distribution with
Yes.
RDW,
Right.
sir. Red cell distribution with terminology.
Iron deficiency anemia. What
It is increased, isn't it?
Mix of pyknocytosis.
It's increased.
It will be increased, sir. There will be
Iron
anisocytosis.
deficiency anemia. Okay.
Yes, sir.
Doctor, I'm going to ask all three of you one simple question, which I asked my MNS postgraduates here. You are three of you. Which year in MD are you in the program?
Final
First year, second year, third year?
Third year, sir.
Third year, sir.
Now, please answer me honestly. How many of you have gone and looked at the blood smears of children? Answer me honestly. Answer me honestly. 0%. This is the defect in our training. I keep telling this. See, you have not had an opportunity, you have not looked at even a single smear in your 12, 20, 48 months of pediatric training. How will you ever know what's really happening to hemoglobin, hematocrit, RBCs? So I'm going to ask you one more question. How many of you have actually done an ECG on a child? Huh?
ECG we have done, sir.
We have done. We have done. Because these are the things that Solomon would very much like, to be able to possess, because you have done. Did you run into any difficulty in taking ECG, and how did you overcome?
I will not be cooperative at first, sir.
So how did you overcome that?
After taking a full feed and making the child sleep.
All right. You divert him, show him a toy, give him a trichloral, etc., etc. Okay. Now, leaving this aside, I'm going to ask you something else. This is a medical diagnosis you are making. I'm going to probably follow. You're going to tell me. Is there any other diagnosis can you think of? What is a social diagnosis? What is a social diagnosis in this child? You are all perplexed. See, for every malady, every illness, every condition that occurs in a child, there is not only a biological medical diagnosis, there is also a social diagnosis. What is that I am talking to? Can you tell me something about social diagnosis? Yes? Social diagnosis.
No,
So
whether
they-
it's right or wrong, you please answer. Each one of you
Yeah.
can give your opinion.
Nutrition status.
Malnutrition status.
Beg your pardon?
Malnutrition and the social economic system.
Malnutrition. So a social diagnosis, let us say you mentioned in the previous one, there was no history of fever or a rash during pregnancy. And then you mentioned about the Christ triad, namely the rubella. Now, see, the mother had not had the MMR vaccine. She would be a very susceptible individual to give birth to a baby with rubella, isn't it? And you also mentioned about somebody not receiving, mentioned about adequate amount of folic acid. If somebody had not had a folic acid, gone to the birth defect, isn't it? And the other thing is when you say social diagnosis, with their location, their earning, their occupation, their beliefs, their perceptions, their attitudes. Now I'm going to ask you, you had spoken to these two parents. When this information was broken to them, the child has serious congenital heart disease requiring major surgery, and the longevity is also uncertain. What was the reaction? How did they respond to it?
First reaction was like, no, money will be there.
No. I want one at a time. Speak slowly.
So the first reaction was that they were not aware of the situation at first. Even after explaining also, they were not able to understand. In that situation, until
But they were totally unaware.
Yes, sir.
And how did you then communicate to them? How did you make them aware? What tools did you use?
We explained it to them, and they even had their phones with them, sir. We used internet communication. Along with that, we tried to communicate with them, sir.
Okay, so in other words, so there is a whole article on this. You read about this in New England Journal of Medicine. I don't want to go further. But the important thing is, you and I need to develop an empathy. That is, this is a poor family, poor income. They don't have the resources to have this attended to, and totally unaware. And you and I tell them the child has a very serious heart disease. Oftentimes they go into sort of shock, disbelief. They become angry at themselves, and the parents start scolding each other. You are responsible. I am responsible. I did something in the past. That's why this curse has come to us. So there is an anger. There's a shame. There's a guilt. All these emotions they pass through. Since it is such a serious illness, they pass through the emotions. You should have a lot of empathy, and the news must be broken. Given to them, in simple sentences and simple messages. So communication becomes extremely important. Social diagnosis. There is no point in saying this child has out because it's important, because nowadays pediatrics will be able to correct. It is important to make the correct diagnosis, intervene, etc. But equally important is to empathize with them, make a social diagnosis and help them. That's
Can I
also
make a
important.
comment, sir? Dr. Ramaswamy and other faculty, can I ask a question or make
Please.
a comment?
Yeah, please.
Yeah, those days when we had to give blood transfusion, we have to ask, because some people, they don't want to give blood transfusion, especially one particular community.
Yeah.
So these are some of the aspects, of course, which you have mentioned. I'm very happy that you asked about social diagnosis. That will give what type of counseling we have to give to
Yes,
this.
correct, absolutely.
Sorry for the interruption.
No, absolutely, sir. Proceed was a nice idea.
தடங்களுக்கு வருந்துகிறோம்.
No, you and I need to be present to give dignity to the case. No, I am very, very happy when Dr. Rajan asked me to chair the session. I am totally incompetent to talk about all these individual lesions and the management because you have bright youngsters like Dr. Solomon, they're all, very, very adept. But what's important at the primary care level, at the first responder level, we need to have our thinking very straight and logical and rational. That's the purpose of my, interacting with them. Okay, go ahead.
You are not upset, that I interpret.
No problem, sir. Sir, or 50 minutes more only, sir. Yeah, only 50 minutes only.
A big one. I'm sorry. Go ahead.
50 minutes, 50 minutes.
Okay. Go ahead. Go ahead, doctor. Go ahead.
Treatment history, cyanotic spells managed and supportive measures continued. Child improved clinically and takes oral feeds well. Developmental history, milestones attained normal for age. The child is able to walk alone, imitates scribbling, speaks meaningful 1 to 2 words, plays simple ball game, and speaks jargon. Diet history, the child is exclusively breastfed after hospital discharge and continued till 5 months of age. No history of sucrose suck cycle. Complementary feed started at 5th month of life along with breastfeeds. As per 24-hour recall method of pre-illness diet, the child consumes a diet.
Okay, doctor, I would interrupt you there. Come to your second line. No history of suck, rest, and suck cycle. Why did you mention that?
For any congenital heart disease with increased blood flow, there will be like the child will have. When there is an increased blood flow in the pulmonary region, the child will be not able to suck. The child is able to suck and he cannot suck and respire together. So there will be a suck and there will be a rest and then followed by he will suck. That is called a suck.
But a little bit more, better explanation. Better explanation from other two.
Cardiac failure.
When the cardiac output comes down, or when there is a lack of oxygen in the blood, what is the physiological response to it? See, you have to think in terms of physiology all the time. There is no point in memorizing. You have to think in terms of physiology all the time. When the cardiac output comes down or when the oxygen level falls, what is the response? How does the body respond to it?
Tachycardia.
Sympathetic stimulation of tachycardia.
What is it due to? What is it due to?
Sympathetic overactivity.
Absolutely, yes. You have a sympathetic nervous system. Yes, there is a discharge of adrenaline, adrenaline. Yes, correct. Absolutely. So there is a sympathetic overreaction and there's the discharge of adrenaline. And then I want to ask you, the heart, what is the nerve supply of the heart? The heart is a, it's a supply to the autonomic nervous system, right? Right?
Yes,
There are two limbs of autonomic nervous system, parasympathetic and sympathetic.
Sympathetic as well as parasympathetic.
So sympathetic nervous system, parasympathetic. Where does the parasympathetic nerves, in which, what does it control? What sympathetic now? Have you read Western physiology? The heart is actually two chambers, two sets of chambers, two sets of valves, two sets of blood flows, everything two. So you have a parasympathetic and sympathetic nervous system. Sympathetic nervous system is all over. Parasympathetic only the upper portions. So when you have a cardiac output falling, oxygen lacking, there is a discharge of adrenaline. And that will obviously produce tachycardia. You give adrenaline to asthmatic child, tachycardia, right? What else would you see on the skin when there is sympathetic overaction? You said suck, rest, suck. Okay. Why does sweating occur? Why does sweating occur? Oh, one moment, doctor. See, the neurotransmitters, acetylcholine in the presynaptic, both parasympathetic, sympathetic. Whereas postsynaptic, it is adrenergic fiber. How could adrenergic fiber give rise to sweating? You are right, doctor, they sweat. I agree with you.
Muscles of sympathetic.
You are right, you are right. The sweat glands are supplied by adrenergic fiber, by sympathetic fibers, but the neurotransmitter is what?
Adrenergic fibers.
Acetylcholine. Check on that.
Acetylcholine.
Yes, that's what happens in scarpine enumeration. You sweat. You sweat. There is a sympathetic activation, but in the skin you sweat. Correct? So you said the baby rests, then takes feed, rest, because you see, taking breast milk is like running 100 yards for a baby. It requires a vigorous effort. See, taking the milk from the mother, it's vigorous effort. Effort is required, energy is required. And you don't have energy, you don't have good cardiac output, sympathetic. So that's how you explain the sweating, perspiration, and tachycardia. Okay? Yeah, go ahead. Go ahead, doctor.
Elicit the history of sucrose cycle from the mother.
The child has a frequent hunger crisis. How many? We should ask about the duration of the time when the child sucks. Usually, every child will suck for at least 30 minutes and then they will have a rest of 2 hours. But this child will have a little bit of sucking and then the child will sleep and then the child will wake again with a hunger cry.
Why does it happen?
Feeds will be there. Because increased calorie requirement will not be met by the milk he sucks.
Anything to do with the breast milk per se? They suck for a very short duration, right? So
Yeah.
what is the initial thing that comes from the breast milk? More of?
More of fore milk, sir. Fore milk contains only water. The hind milk is rich in calories actually.
So they
So
don't
the
get
child,
sufficient amount of hind milk and fat content, right? So because of
Yes,
that, their hunger is not satisfied and hence they awaken early and they again cry for milk. Okay, that is a specific history for sucrose cycle.
Go, doctor. Move along, doctor. Move along. Move along.
yes, sir. Immunization history.
You skip this, doctor. You skip this. Move along. Okay.
Immunized up to age according to national immunization schedule, including pneumococcal vaccines given. Last lesson at
Make these histories very short. Okay, immunize. Yes.
family history.
No significant family history. Go to the next.
Very good. Very good. Three. Yeah.
These
No
also
other, no history.
nothing specific.
Significant
Go to the
allergic
next.
history or contact history. Socioeconomic history.
Go to the next.
Case
Good.
summary: 18 months old, developmentally normal male child, born to third-degree consanguineous parents with uneventful antenatal history, diagnosed to have cyanotic congenital heart disease in the immediate newborn period, operated at the newborn period, on regular medication as recommended by the operated institute, discontinued the medications as the mother has been admitted for second delivery with the child was under the care of the grandmother, noted to have developed a bluish discoloration following by episodic intensification of cyanosis, probably cyanotic spill, and the child was brought to hospital for further treatment and management. Fully immunized up to age according to national immunization schedule with a calorie deficit of 225 kilocalories and protein deficit of 2.3 grams per day, belonging to upper lower class according to modified Kupusamy scale. Probably the child is having cyanotic congenital heart disease, which presented soon after birth, requiring admission and surgical correction. Now having frequent cyanotic spills. It's probably due to the previous shunt failures.
Okay.
General examination. Child awake, alert, interested in surroundings, not tachypnic, dyspneic, no pallor, icterus, edema, significant lymphadenopathy, grade 2 clubbing plus, central cyanosis plus. Vitals, temperature 98.4 degree Fahrenheit degree in axilla.
Vitals normal. Go to the next. Go to the next.
Anthropometry, child is under moderate acute malnutrition according to WHO growth charts.
Yes, go to the next.
Head to foot
moderate
examination.
yes.
Head to foot examination, skull shape normal, AF closed, hair normal, no dysmorphic faces, no cataract, squint, ptosis, nystagmus, no telangiectasia, no signs of vitamin A deficiency. Ears normal, grade 2 clubbing of fingers and cyanosis of fingers and toes noted, central cyanosis plus, no oral thrush, no dental caries, tongue normal, dental formula 2:1:1, skin BCG scar plus, no petechia or purpura seen, neck normal, in the chest, midline thoracotomy scar plus, scar in the left axillary region plus, scar in the epigastric region.
Doctor,
plus.
I will interrupt you if you don't mind. Tell me how you auscultated. Tell me your usual, what is the technique that you use and how did you auscultate?
Usually make the child comfortable, sir, by sitting in the mother's lap.
Okay, I'm giving this baby as on mother's lap, quiet.
Yes, sir. While distracting the baby, I'll auscultate.
No, baby is mother's lap, quiet, comfortable, sleeping. And let us say the chest is bad for you to inspect and also palpate and auscultate. I give you a stethoscope. Tell me how you proceed with auscultation and what do you look for in auscultation?
I will start from the mitral area.
Go ahead. Whatever you did, tell me. Then I will tell you what I would do.
I'll start in mitral area. I'll auscultate for heart sounds, S1 and S2, along with any murmur. In all that 4 areas, mitral, tricuspid, pulmonary, and aortic area.
Is there any order in that? Is there any order? Mitral, tricuspid, pulmonary, aortic. Is there any order? No, you proceeded rightly. Okay. This is the, Z, the alphabet Z. You told me the reverse. You wrote me mitral area, correct, tricuspid, go to pulmonary, aortic. So it is a Z. You can come from the aortic area, pulmonary, down the left parasternal border, tricuspid area, and go to mitral area. So you must have one technique you should use consistently. Normally it comes with, aortic area, pulmonary area, down the left parasternal border, come to tricuspid, mitral area. This is the other way. Okay, now you hear a murmur, let us say in the left parasternal border. What is your next step?
I look for the intensity of the murmur, whether it is a normal, the left parasternal.
Okay. Now, how many times do you auscultate? Once, twice, or thrice? I'm sure all this would have been told to you. See, how many times should you auscultate? What is your ability to discriminate the sounds and murmurs?
At least 3.
Huh? How about the other two? The other two trainees. See, all these Dr. Solomon will give you, all these details he will give you all about heart disease. They're experts. But I am not here to talk about that. I'm not competent there. The other two, how many times would you auscultate? Okay. Now I'll give you a reference. Now you go into MRCP, cardiovascular system examination and read that and practice it. So I won't waste your time. But what I'd like to do is to commence in one area like, aortic, pulmonary, and then parasternal borders, then, your tricuspid, mitral area, and then do it once, do it second, do it 3 times. First heart sounds, then murmurs, again the reinforce. Okay, what is that the cardiologist when they auscultate? What single point do they focus on? Dr. Solomon would, I'm sure, confirm that. See, the pediatric cardiologist, they keep on auscultating. Of course, first sound, second sound, systolic murmur, all that is given in your book, diastolic murmur, etc. But what is that one single auscultatory finding they would insist, they would actually focus on?
Presence of chill. Presence of chill.
One at a time. What single I'm sure Dr. Solomon would support my statement. they would focus all the time on the pulmonary second sound. It's a very important finding for them.
Because,
Pulmonary second sound.
sometimes
Am I
you
right,
have
Dr.
a-
Solomon?
Yes. So
Please tell them the
major
importance of auscultation.
critical congenital heart disease, sometimes you may not have any murmur, especially some duct-dependent lesions, you may not pick up any murmur. But S2 is the most important thing in congenital heart disease. Presence of a single S2 or a split S2, whatever it is, that is more important. And most of the murmur will be some kind of a soft ejection systolic murmur, and you may not be able to come to any specific conclusion based on that. So S2 is very important in congenital heart disease.
So I'm very happy Dr. Solomon has emphasized this point. Now I'm going to ask them again, doctor, you hear a murmur, let us say in the aortic area, what's your next step?
Whether it is a pathological murmur or an innocent murmur.
Okay, let us say, I won't go to that. What is your next step in auscultation? Let's not interpret it. I hear a murmur in the aortic area. I have done it once, I have done it twice, I have done it thrice. Initially, I focus on the heart sounds. Second, I focus on the murmurs. Third, I wanted to confirm my findings. I did it in recommend position, I did in upright position, etc. I did it in inspiration and expiration. I did with a bell and diaphragm. These are all the techniques. I hear a murmur in the aortic area. What is your next step? You see, it gets transmitted to the aorta.
Transmitted to the
Aortic.
Okay, you hear it over the pulmonary area. Where do you extend your auscultation? To the left axil.
Left axil.
You hear a murmur in the mitral area.
Left
Left
axil.
axil. Radiating
Huh?
to left axil. Radiating to
Okay.
left axil.
Now, okay, you have done all this, doctor. There is a murmur here. Sounds appear normal. Should you turn the child on its abdomen? Should you auscultate the interscapular area? Yes or no?
Yes, sir. At the back.
Why?
In other words, what is the importance of auscultating the interscapular area when you have a cyanotic heart disease?
Especially in a cyanotic.
In PAPVC, there will be murmur, continuous murmur, so that will be heard at the back.
Collaterals. In
Interscapular.
TOF, we have to look for collaterals.
Pardon?
Al
In
kappa.
TOF, we have to see for collaterals, hyperpulmonary collaterals.
Cause large atopulmonary collaterals can cause
Al
murmur.
kappa.
Anything else?
Sir, TAPVC, there will be continuous murmur that will be heard at the back.
Mostly in the anterior part of the chest. Anything else?
Have you heard of pulmonary airway fistula?
Yes, sir.
Okay, all right. So I leave it to Dr. My moderators to proceed further. I'll stop all my questions at this point.
At the
Okay, please
end
go
of
ahead.
the general head to foot examination of other PGs, the head to foot examination, what is now your inference? After the child is having a cardiac problem, head to foot examination, at the end of that, what is the inference? Is there anything positive in the head to foot examination other than the cardiac manifestation of cyanosis? So for the other PGs, no, for a normal face is normal skeletal, if there is no anomalies, that gives a clue that it is an isolated cardiac anomaly. So always remember, cardiac anomalies can occur as a part of
Syndrome.
syndromic anomaly,
Syndrome.
association anomaly, yes, sequence anomaly, and also part of an in utero infection. So for inference for the PG exam going, at the end of your head to foot examination, that is the inference of that. Yes. Yes, now you can proceed with the other presentation. Yes.
Systemic examination, cardiovascular system inspection, skin over the pericardium normal, midline thoracotomy scar plus, scar in the epigastric region plus, scar in the left axillary region plus, no dilated vein scenes, trachea appears to be in midline, no pericardial bulge seen.
Why did you say thoracotomy scar midline? What is the relevance of the midline scar?
Sir, usually the corrective surgeries will be done in the midline.
Why patent ductus arteriosus, they will do it with the thoracotomy scar. Corrective surgery can be done. The midline scar means something specific.
Open cardiac surgeries maybe.
What are the other scars you look for? Where else will you look for scars?
Sir, the left axillary region and the
What are
right
those scars
axillary
due to?
region.
You said there's some scar in the epigastric and left axillary. What are the
Yes, sir.
scars?
Left axillary is for DT shunt lesions for palliative shunt
Child has
surgery.
a
There will
small
be
scar in the left axillary region, right? And in the epigastric region. What are they due to? They are small scars. No, you can't do a heart surgery through that.
that is due to the post-operative complication the child develops. It is due to the pneumothorax. And in the epigastric region, it is for the brain.
Mostly it is because of the drains kept. No? Mid-brain, that epigastric region probably mediastinal drain, and the left axillary probably a pleural drain. So what other areas will you look for large scars? One is the midline sternotomy.
Midline scar.
Yeah. Anything else? Where else do they operate?
Infraclavicular region, there may be a scar for patient.
Lateral thoracotomy. So what are the surgeries that are done, congenital heart surgeries that are done?
Correct. That's what Dr. Solomon is asking you. Okay, good. Very good.
Thoracotomy. Surgeries done through left posterolateral thoracotomy approach.
What are the procedures they are doing for no? For each and every, there are many differential diagnoses. So what are the surgical? Yeah, yes.
Context procedure.
It is done through
Glen shunt.
No. Basically, PDA ligation, coarctation repair, and sometimes very rarely BT shunt can be approached through left posterolateral thoracotomy scar. So if it is a sternotomy, it's basically, I mean, this surgery was done at day 12 of life, right? So what do you think was the surgery done?
Palliative surgery. PT shunt.
So cyanotic congenital heart disease, probably which presented with severe cyanosis, probably gives you a clue it is a cyanotic congenital heart disease with decreased pulmonary blood flow. So they have done a surgery to increase the pulmonary blood flow, probably a BT shunt. And there was another question from Dr. PRC, sir. What do you think was the medication that was discontinued which led to all these complications? Because the child was apparently normal till 1 year, right? After 1 year only, after discontinuation of medicine, the child developed these complications.
For the patency of the shunt, the child would be given some medications for anticoagulants, sir.
Do they give anticoagulants?
What do they give
Antiplatelets, sir.
Yeah, basically they generally put them on antiplatelet, like
platelets, yes, sir. Aspirin, clopidogrel.
Mostly aspirin, very rarely they combine it with clopidogrel. Proceed.
No visible pulsations over neck or chest wall or epigastrium. No jugular venous pulsation seen. No intercostal or subcostal retractions present. Back normal. No visible pulsation seen. Palpation. Tracheal portion confirmed in the midline by palpation. Apical impulse felt over left fourth intercostal space in the midclavicular line. Normal character. No parasternal heave. No palpable thrill. No palpable pulsations or palpable sounds. Mitral area, S1, S2 heard normally, no murmur. Tricuspid area, S1, S2 heard normally. A pansystolic murmur of grade 3/6 heard in the left lower sternal border in the fourth intercostal space. Pulmonary area, S1 normal, single S2 heard. Grade 3/6 and ejection systolic murmur, best heard in the left second intercostal space. Aortic area, S1, S2 heard normally.
Can you go back to that slide? Auscultation. Okay.
Respiratory system, other systems are normal. Case summary: 18 months old, developmentally normal male child, born to a third-degree consanguineous marriage, fully immunized up to age, diagnosed as cyanotic congenital heart disease, operated at birth, presented with complaints of episodes of cyanotic spells, who had signs of central cyanosis and breakthrough clubbing, with ejection systolic murmur over left upper sternal border, with a single second heart sound and pansystolic murmur in the left lower sternal border. This is a case of congenital cyanotic heart disease with a decreased pulmonary blood flow, with palliative surgery done, now presented with cyanosis and cyanotic spell, probably due to non-functioning of shunt, in sinus rhythm with no features of cardiac failure, infective endocarditis, with moderate acute malnutrition according to WHO charts, fully immunized. So, as is the case of
Yes, take a proceed.
that's the case of congenital cyanotic artery decreased pulmonary blood flow. It's a complex disease, so I would like to give a differential diagnosis. And it also presented at birth.
So how do you want to substantiate your diagnosis? Why did you come to this diagnosis of cyanotic heart disease with decreased pulmonary blood flow?
The child has cyanosis at birth along with breathlessness. The cyanosis was so severe, and along with this investigations also, the investigation done at birth also provided.
Could you please show us the chest X-ray, ECG, echocardiography findings?
So the chest X-ray showed pulmonary oligemia, sir. Along with normal
Do you have the film? See, normally the pediatric cardiologist would like to look at the chest X-ray, ECG, and then they do echocardiography to confirm the diagnosis structure. So if you have them, can you put them up?
Have you put in the slides?
Okay, that's right.
Rekha, it is there, or at least you tell the findings.
Sir, I would like to tell the findings.
Oh, yes.
At birth, the X-ray showed pulmonary oligemia and a small heart, that is a normal heart size. In ECG showed a left axis deviation and left ventricular hypertrophy. The echo showed.
Please go slow. ECG showed.
Yes, sir. ECG showed left axis deviation along with left ventricular hypertrophy, sir.
What do you mean by left axis deviation? You are familiar with some basic ECG interpretations?
Yes, sir.
Present ECG or newborn period ECG?
Newborn period ECG.
Left
What do you mean by left axis deviation? Yeah. See, if it was indeed diminished blood flow with right ventricular obstruction, I would expect the right heart to be much more prominent, and you will accept more of right axis. Now, can you tell me about ECG, some basics about your axis? You are given an ECG tracing doctor. Nowadays, the computers give you, at your level, I give you an ECG strip. What is that you would look for? Tell me one of you.
Sir, look for the rate of.
You're going to talk to Dr. Solomon, but he will ask you. Okay.
Yeah, you should go in order. I mean, just straight away, don't jump to axis. Huh? So how do you interpret ECG?
So
go ahead. One of you.
Whether the leads are placed correctly, look for the heart rate.
Leads are placed correctly, technically satisfactory ECG I give you. I give you a technically satisfactory ECG.
Sir, look for the rhythm. Look for the heart rate and rhythm. You check for the RR interval and the division of total divided by
okay.
300.
So you're okay. You're
number of log space RR interval. And
all right. Okay. You are familiar with that. Okay, rate, rhythm, okay, axis, PR interval, P wave, QRS, all that you are familiar, or you listen to YouTube, become familiar. All right. So how do you explain the left axis here?
So if you find a left axis deviation in a three-month-old baby with cyanosis, what would you think of? Endocardial defect, generally they have an extreme right axis deviation or a northwest axis or a superior axis. When you have a presence of left axis deviation with LVH, probably you can think in presence of cyanosis, probably you can think of because most of the cyanotic heart lesions with decreased pulmonary flow, most of them have RV dominance. Okay, usually they have right axis deviation.
That's right.
That's what. But if you have a feature of left axis deviation with LVH, probably gives you more clue. Probably you're dealing with a tricuspid.
Yeah. So Dr. Solomon gives you the explanation. Yeah.
Dr. Rixi, I want to make a mention. Your voice is waxing and waning. Keep the mic a little nearer.
Okay.
Because some part of it is very clear,
Okay.
And this thing, no, the later part of it becomes very soft.
Okay.
So Dr. Solomon has given you an explanation for the left axis. Very correctly, he said the tricuspid atresia means, the right ventricle is not there mostly. It's all left ventricle, that's left axis. Okay, go ahead.
So the echo finding at the newborn period showed a tricuspid atresia with a severe pulmonary stenosis with a restrictive VSD and a large ASD with the great arteries in the same position along with the pulmonary arteries confluence is normal.
Okay. Have you
With the PD.
have you witnessed an echo being done by the cardiologist, or have you done it on your own? No, as a postgraduate trainee, when you had a child like this, did you go with this child and stay with the cardiologist? And did you see how he did the echo? Have you? So can you tell me how the cardiologist proceeded? Will you tell me how the cardiologist proceeded with the transducer doing an echocardiography? If you had been there, you'd be able to tell me.
Yes, sir. The first place is in the epigastric region.
Now, what are the basic views through which you diagnose structural heart lesion?
The fourth chamber view, so we'll start with the fourth chamber view, then the subcostal region.
Parasternal view.
Parasternal view and the short axis and the long axis view, sir.
Okay.
Parasternal view.
And how do they report? How do the cardiologist report?
We'll first mention about the sinus status, the sinus corridors, and if it is a neocardia or dextrocardia, and then we'll comment about the relation of the great vessels, which is the northern.
Could you please tell me in one sentence, how do they proceed? Do they proceed from the bottom to the top or top to the bottom? When they start describing?
Bottom to the top, sir.
Bottom to the top.
Okay, right. All right, go ahead. So you are familiar.
Auscultation slide.
Auscultation slide. Dr. Solomon wants auscultation slide. Please bring back.
Serious examination, auscultation. Yes, auscultate that points, no, not that video. Were findings in auscultation previously. Yeah, yes.
So now we have come to a diagnosis of tricuspid atresia with severe pulmonary stenosis based on an echo report. And you said a palliative shunt was done. So can you explain the auscultatory findings? What is the reason for that ejection systolic murmur? What is the reason for the transsystolic murmur?
Yes, so the ejection systolic murmur is due to the pulmonary stenosis. The pansystolic murmur is due to that restrictive VSD which was there.
Restrictive VSD.
Restrictive VSD should give you short.
So generally, basically in tricuspid atresia, theoretically, what are the murmurs you'll expect in tricuspid atresia with pulmonary stenosis?
Yes, in pulmonary stenosis, there will be ejection systolic murmur. If there is a VSD, there will be pansystolic murmur. If it is large enough, there will be a small murmur, but when it is restricted, there will be a pansystolic murmur of 3%.
No, when we say tricuspid atresia with pulmonary stenosis, will that be a VSD or not?
Yes, sir.
VSD is that. So generally, does it cause a murmur?
Yes. If it is restrictive, it will cause murmur.
Most of the cases will be an unrestricted VSD. Okay.
Non-restrictive VSD.
The non-restricted VSD. When we say it's non-restricted, there is a pressure equalization between the right and left ventricle. And because of that, the shunt that happens there will not cause any murmur. So putting the reason of a pansystolic murmur is because of a VSD is not correct. Okay. There are very rare causes. Sometimes you can have a restrictive VSD, but that cannot be your diagnosis at this part. Okay. So do you have any other explanation of pansystolic murmur there? Forget it is a tricuspid atresia, some other congenital heart lesion with a pansystolic murmur at the left lower sternal border. What is the basic DD for pansystolic murmur? What is the differential diagnosis you would like to give for a pansystolic murmur other than a VSD in the left lower sternal border?
Any single ventricular truncus arteriosus.
Left lower sternal border. What is the valve located below that area? Yeah, so sometimes you can have a common AV valve with a significant AV valve regurgitation. Maybe in a cyanotic heart disease, probably you can say it's because that can cause a pansystolic murmur. In the acyanotic heart disease, that is different, either a VSD or a TR due to some other reason. But when you have cyanosis, presence of a pansystolic murmur due to restrictive VSD is a very rare cause. Okay, should be very careful when you say pansystolic murmur is due to VSD. And you said single S2, right? I would like to know the intensity of the sound, whether it was normal or loud.
It was loud.
The child had only a systolic murmur, no, not a pansystolic murmur. So put as a pansystolic murmur. There was some systolic murmur in the external border. Okay, no problem. So actually, sir, Richard sir, the child had a systolic murmur in the external border. It was not a pansystolic murmur.
When you put two different types of murmurs, you should have a reason for them. Okay. And why is it important to know about the intensity of the S2? You said a single second heart sound is heard. But is intensity important?
Loud S2 will be due to this cyanotic lesion, sir. When the child goes in for Eisenmenger syndrome, the sound will be it will be short and harsh. Short.
Are going to Eisenmenger syndrome. No, in cyanotic heart disease. With decreased pulmonary blood flow. Okay, we'll take the common lesion as a TOF.
Yes, sir.
In TOF, what will be the oscillation finding in the pulmonary area?
Single S2, sir. Soft single S2, sir. Soft and single S2, sir.
Soft and single S2. What is the reason for the softness?
Because of reduced pulmonary flow across the valve.
What is that sound you are hearing in TOF? What is that sound?
Sir, aortic
valve closure or the pulmonary valve closure?
Aortic sound.
Aortic sound only will be heard in TOF, sir. Because
Aortic
it is anteriorly placed over the pulmonary valve.
hearing is the aortic valve closure sound. You are not hearing the pulmonary valve closure. Why is it?
Anteriorly placed aorta due to overreading.
Because of the hypoplasia of the pulmonary annulus, it's much more posterior. Generally, it is too single and loud. Okay, because it's much anteriorly placed, it's much easily heard over the chest wall. Proceed.
I'll start with the investigation. I'll start.
What happened to the shunt? Do you think shunt is open or is it closed?
The shunt is closed, sir.
So how will you pick up a shunt in a child? Other than
Usually there will be a continuous murmur when a shunt is placed. So when we don't hear that continuous murmur.
where will you auscultate for a shunt murmur in a cyanotic child?
The left. Over the lung fields.
Anterior.
Over the lung fields, sir.
Right.
Anterior lung fields.
Anteriorly, which side? Left side.
Right side, sir.
So it depends on where the shunt was done. Here, right
Shunt was done.
or left PT shunt. If it is right PT shunt, it is on the right side. If it is a left PT
Right
shunt,
side.
it is on the left side. So you should auscultate on both sides anteriorly. Okay.
In this case,
Go to the next, your investigation. Here, we'll have a clinical discussion. Yes.
specific investigations, chest X-ray, ECG, echocardiogram with the color Doppler, cardiac catheterization. If findings are doubtful in echo. Then routine investigations, sir. Hemoglobin with RBC indices, hematocrit, total count and differential count.
Go to the next. Routine investigation will do. Go to the next.
Further, cardiac MRI can be done.
Each and everything you say, you offer so many differential diagnoses. What will be the chest X-ray in cyanotic congenital heart disease? So for the benefit of the previous, yes. Chest X-ray you have put Rekha. You have given so many differential diagnoses for the cyanotic congenital heart diseases. So what will be the characteristic X-ray findings in each?
This X-rays can be divided into two
I
fields.
think
Pulmonary.
Ritu sir will give
In
more on
other
that.
words, no, I mean, madam is asking, there are certain specific findings which will help you to diagnose specific congenital heart lesions.
Yes, ma'am.
Can you tell me specific findings for a particular congenital heart disease? Like maybe you'll take one by one. For Epstein's.
For Epstein's, there will be increased pulmonary blood flow, boat-shaped, box-shaped hearts will be there.
In Epstein's.
Yes, sir.
You will have cardiomegaly, but why should there be an increase from blood flow?
But there is no, there is a tricuspid
We have
regurgitation.
discussed about intermittent cyanosis also, right? So generally,
Yes.
the pulmonary blood flow in the neonate especially will be less only, okay? And if at all, you can have probably normal pulmonary blood flow or decreased pulmonary blood flow, not increased pulmonary blood flow. So if you have a newborn with cyanosis, there is cardiomegaly with decreased pulmonary blood flow, pulmonary oligemia. What will be a differential diagnosis with respect to structural cardiac lesion? One is Epstein's. Anything else? Cardiomegaly with decreased pulmonary. Decreased pulmonary blood flow.
Transposition of great arteries with the VSD and pulmonary stenosis.
No, total anomalous with obstruction.
Cardiomegaly with normal or decreased pulmonary blood flow. One is Epstein's, other could be critical pulmonary stenosis. Okay, duct dependent lesion. Do you have an agon side appearance?
Transposition of great vessels.
Did you have an agon side appearance?
For this case, sir.
What is the associated finding with the agon side appearance? Anything else? The upper part of the mediastinum? Just
Narrow
TGA. Narrow pedicle. Why is there a narrow pedicle in TGA?
Narrow pedicle.
Why is there a narrow
Both
pedicle?
the great arteries are superimposed over each other, sir, in the X-ray.
And sometimes the thymic is hypoplasia. And any other specific finding in PAPVC? We already discussed
Snowman
PAPVC. What is the specific
Like
finding?
Normal appearance.
HMD like picture.
From the ground glass appearance. Okay.
Appearance, yes, sir.
And when you have a figure of 8,
Supracardiac PAPVC.
but the manifestation in newborn is quite rare. As they grow older, you will get the typical figure of 8. Okay. So you have a baby with probably a normal heart, but increased pulmonary vascularity, but saturation is very low. What will you think of? Normal heart size or mild cardiomegaly, but increased pulmonary blood flow. There's a lot of lung vascularity seen, but the saturation is quite low. What do you think? So in a truncus arteriosus in the probably 2 weeks of life, will you expect a saturation of 90 or 60? 2 weeks of life.
90.
So generally it's a increased pulmonary blood flow situation. Generally you have a high saturation. There is only one condition where you have increased pulmonary blood flow, but very low saturation. What is that structural heart disease? Would you like to start some medication immediately?
Single ventricle.
No. It's TGA, okay. So TGA with intact ventricular septum, you have increased pulmonary blood flow. That is very low saturation. Why is there very low saturation TGA in spite of a high pulmonary blood flow? Pardon? I couldn't hear you.
Intracardiac mixing of blood.
Supracardiac?
Infracardiac mixing of the blood.
No, is there very low saturation?
The parallel, it remains as a parallel circulation, sir.
Okay, so what decides the saturation? Is it the
Aorta
pulmonary
arises
blood
from
flow?
the right ventricle.
So normally the principle is when you have a high pulmonary blood flow, you should have a high saturation, right? But in TGA, you have high
Yes,
pulmonary
sir.
blood flow, but
Oh,
what
yeah.
decides the saturation in TGA?
The aorta
So it depends on the mixing of blood that happens within the heart. Could happen at the ventricular level or the atrial level or the PDA level. So it depends on the amount of mixing. The saturation TJ is decided. Okay, so that is one condition where you have increased blood flow with very low saturation. Okay, proceed.
Yes, Rekha.
So I think,
Rekha, proceed.
Dr. Rajendran, how many more minutes left, Dr. Rajendran?
10 more minutes, sir. 10 more minutes.
So actually, the idea of giving this case to the PG is not a straightforward case. Nowadays, no, we are getting more of newborn conditions getting corrected, sir. So most of the time, they are getting admitted to the PICU very often. So mostly during practical examination, during ward rounds, similar cases are being kept. Our PGs know most of the time they are finding it difficult to present such cases as a ward rounds. So this case was given with an idea that they should get an experience of presenting similar cases. That is why we are given this case, sir. So PGs actually, they were voluntarily told that they are going to present this case, but this is a very difficult case, of course, I know. And we learned a lot of things from Dr. Ramasamy sir, who has given very nice points. So usually these were all the questions, whatever is going to be the diagnosis. During the discussion from the earlier part, always our PGs, like sir pointed out, it's a very good thing, sir, that I am also now wondering, our PGs, we are saying, go to the path lab and see the peripheral smear. You go and see the red cell indices, and most of the time we are asking questions. But in spite of that, they are having a fascination towards syndromic anomalies and all those cases, rarer cases. But the common things, they are not concentrating. Good things are, you were pointed out that, and this is for all the PGs. So always common things first, then you go to the other cases. So except for the history that the child was operated in the newborn period, the child admitted in the pediatric ward almost like with a spell like a pathology. So when the child was admitted without the previous records not available in hand, so all were in a fix. But we managed like this is like a spell.
Yeah.
So the idea of giving the case was to empower our PGs to present the difficult cases when they are kept for the ward rounds, sir.
I think, you are absolutely right, Professor, because over the years it has changed. In 60s and 70s, most of these cyanotic heart disease, except Fallot, they all expired in a matter of few months. But it is no longer 21st century. Everyone is correctable and everyone is allowed to live. Now there's so much of technology, so much of specialization, so much of expertise. Now pediatric cardiologists are available almost every city. I fully agree with you. I think the spectrum is completely changed. But still, since at a primary care level, at a general pediatrician level, we need to do certain things on a very rational basis. But I would think, we should have a pediatric cardiologist for all subspecialties available to us to help us, to manage them better. I don't think we'll be able to manage these problems without the help of subspecialists really very rationally. So we need almost all teaching institutions, I think, should have subspecialists to support the general pediatricians, especially in the ICU. And I also run a similar situation at Masonic. What we do, we stabilize the children and respiratory distress, we support the respiration, and we get the basic ECG, chest X-ray, basic studies. Then we go through this process of differential diagnosis. Then we get the cardiologist to come immediately, and then we interact with him, and then finally, it goes on like that. I agree with you because
Rekha, you put your differential diagnosis. No, cardiologist sir will enlighten us more on your differential diagnosis. So put a list of differential diagnosis. That's like no.
Yeah. Dr. Solomon, could you please, categorize these, for the subdivisions and tell us, for our benefit, can you just make it simple for us?
Yes, sir. So basically from the clinical findings, basically auscultative finding, you have an outflow tract murmur, ejection systolic murmur. in presence of a cyanosis. And basic diagnosis which we can offer here is a cyanotic annular disease with decreased pulmonary blood flow. And this is probably a top physiology. So under top physiology, clinically to differentiate between individual lesions is quite difficult. So when we say top physiology, we put tetralogy of Fallot as the first diagnosis because that is the most common congenital heart disease with cyanosis presenting with decreased pulmonary blood flow. So other than that, after that, you have many complex structural lesions. You can have any type of structural heart lesion with pulmonary stenosis. So if you have to list it out one by one, it could be tricuspid atresia, VSD-PS, or a DORV, VSD-PS, or any single ventricle with PS, or a complex AV canal defect with PS. All these lesions will have a combination of pulmonary stenosis. So that is a common factor. Otherwise, you can have any type of complex VSDs or complex defects in intracardiac. But basically, they are all grouped under top physiology. This is basically to arrive at a diagnosis, okay? Because the two broad categories is one is cyanotic annular disease with decreased pulmonary blood flow, other is cyanotic annular disease with increased pulmonary blood flow. So increased pulmonary blood flow management is totally different. So for cyanotic heart disease with decreased pulmonary blood flow, management is totally different. So once we come to this diagnosis, then we need the help of investigations, basically starting with X-ray, ECG, then echo. So ECG wise, most of them will have right axis deviation with RVH. Probably the one condition where you can pick up with the ECG is the tricuspid atresia, which will have a left axis deviation with LVH. Sometimes in pulmonary atresia, intact ventricular septum, you can have a left axis deviation. Otherwise, most of them will have an right axis deviation and right ventricular hypertrophy. So, but X-ray gives you a lot of clues, especially when these children are not operated. Pre-operatively, you can have good pickup with the X-ray. So as we said, just look whether there is increased pulmonary blood flow, decreased pulmonary blood flow. Then also look into whether the heart size. So most of the congenital heart disease with decreased pulmonary blood flow will have normal cardiac size and pulmonary oligemia. That is a list of conditions you have listed. But when you have a normal cardiac size or just a mild cardiomegaly with increased pulmonary blood flow in presence of deep cyanosis, probably the diagnosis could be PGA. And a few specific points for specific disease. One is other is the ground glass appearance, which is an obstructed TAPC, egg on site for a TGA. Other than that, from X-ray also, sometimes it is difficult to go to diagnose a specific cardiac lesion. So after that, the only investigation left is for us echo. So from the echo, basically, we finalize whether it is a single ventricle physiology or a biventricular physiology. So whatever is the complexity of the lesion, we should know whether we can go along the single ventricle pathway or a biventricular correction. So to put in simple terms, if it is a single ventricle candidate, we cannot correct all the cardiac defects. So we will have to do stage surgeries whereby we increase the level of oxygen saturation. If it is a biventricular repair, maybe after one or two stage surgeries, we can achieve a structurally normal heart. So in single ventricle surgeries, the palliative surgeries that are mainly done are, one is pulmonary arterial banding, then Glenn shunt, BT shunt, and Fontan. So the final surgery done in all single ventricle palliation is Fontan. So before that, it could be either BT shunt followed by Glenn leading to Fontan, or it could be a PA banding followed by Glenn leading to Fontan surgery. So if you have to understand this individual surgeries, so one surgery is done basically to decrease the pulmonary artery blood flow. So for which type of surgeries would you want to decrease the pulmonary artery blood flow? Only for lesion, and there is increased pulmonary blood flow, and there is which is not amenable to biventricular repair. So basically, any complex single ventricle condition without pulmonary stenosis, the first surgery which we do is a PA banding. Once we do PA banding, we have decreased the pulmonary blood flow. We make this child suitable for further palliative surgeries. So one important thing which you should know is the final surgery, which is Fontan, is basically a complete connection of the venous system blood into the pulmonary circulation, whereby we divert the blood away from the heart. So basically, when we say single ventricle, the chambers within the heart cannot handle both the pulmonary and systemic circulation. So the most important circulation which we need is the systemic circulation. So that is taken care of by the aorta. So what we do, we take away the venous circulation and put it directly to the heart. If you do it in a staged manner, the first surgery which is done is a Glenn shunt. So in Glenn shunt, you anastomose the superior vena cava to the pulmonary artery. The next surgery which we do is the IVC connection to the pulmonary artery.
Other arteries.
So very rarely they do Fontan as a single surgery, whereby both these things are done together. SVC connection to pulmonary artery and IVC connection to pulmonary artery. But usually most of the children who are diagnosed in the early infantile period, they go through a stage correction, whereby first surgery which is done is a Glenn, whereby SVC is connected to right pulmonary artery. And probably as they reach 3 years, 4 years of age, we connect the IVC also to the pulmonary artery, thereby completing the Fontan circuit. So what is the main difference here between a normal biventricular circulation and a Fontan circulation? There is no subpulmonary ventricle. So the blood flow to the lung is very passive. So any increased pulmonary artery pressure or increased pulmonary vascular resistance will not allow the Fontan to function. So that is the reason when we have increased pulmonary blood flow, we do a PA banding and try to bring down the pulmonary artery pressure as soon as possible, so that they might be suitable candidates for future Glenn or Fontan. So basically in single ventricle surgeries, you should know pulmonary artery pressure should be very low for the final surgery. So when you start with the cyanotic heart disease with increased pulmonary blood flow, we directly band the pulmonary artery to decrease the pulmonary artery pressure, then do a Glenn and finally a Fontan. Whereas when you have a cyanotic annular heart disease with decreased pulmonary blood flow, initially the problem is there is no pulmonary blood flow, right? So for that, you do a systemic artery to a pulmonary artery shunt, whereby you increase the amount of pulmonary blood flow. Once you do the BT shunt early, next you'll have to stage it with a Glenn. You take off the BT shunt, then connect the SVC to pulmonary artery so that you can keep the pulmonary artery pressure low. Then final surgery will be Fontan. So in order, if you have to remember, cyanotic annular heart disease with decreased pulmonary blood flow will be very early presentation, do a BT shunt initially. After 3 months, Glenn shunt. At 3 to 4 years, Fontan. For cyanotic heart disease with increased pulmonary blood flow, around 2 months PA banding, probably Glenn shunt around 5 to 6 months. Then finally, Fontan at 3 to 4 years. I think I'm clear. I tried to make
Yeah, I think yes. Dr. Solomon very beautifully put, very beautifully rationally put. I think for a general pediatrician like me, it's very, very useful to remember these points that you have mentioned. Thank you.
Yes, thank you,
Dr.
sir.
Rekha, can you stop slide sharing?
Yes,
Rekha?
I like to thank those young doctors, products of 21st century, for staying, for presenting it so well, and also, all the questions that I put to them. I hope they were all taken in a good sense. They're all very bright people, very intelligent people.